Welcome to the CurePSP webinar series. CurePSP's mission is to provide education and support for patients, caregivers, families, and healthcare professionals affected by PSP, CBD, MSA, and related brain diseases while funding research towards a cure and prevention. Webinars are made possible by the generosity of donors and other supporters. My name is Bruce Gianelli, and I am the Director of Communications and Marketing at CurePSP. The topic of our webinar today is Occupational Therapy Treatment for PSP, CBD, and MSA. Questions for our speaker will be accepted at the end of the presentation. At that time, a chat box will appear at the bottom of your screen where you'll be able to type and submit any questions you may have. We will field as many questions as time allows. At this time, it is my pleasure to introduce our speaker today, Rick Vandendolder. Rick received his BA from the University of Connecticut in 1976 and a certificate in occupational therapy from the College of St. Catherine in 1991. He is a senior occupational therapist on the Struthers Parkinson Center interdisciplinary team. He has worked in healthcare for 33 years, including hospital acute care, rehabilitation centers, long-term care, home care, and outpatient treatment. For the past 17 years, he has worked primarily with patients with Parkinson's disease and related movement disorders, providing assessment, treatment, home evaluations, and job site evaluations. He has presented at professional education conferences locally and nationally. He has been a faculty member of the National Parkinson's Foundation's Allied Team Training for Parkinson's since its inception in 2002. Rick?
Thank you, Bruce. Well, today I'd like to talk a little bit about the atypical Parkinson's syndromes. The majority of my work over these years has been with individuals with Parkinson's, but I also very often see individuals who are afflicted with one of these conditions that sadly don't have the effective treatment that Parkinson's disease has. And so we're going to be talking about progressive supranuclear palsy, multiple systems atrophy, and corticobasal degeneration, which is sometimes called corticobasal ganglionic degeneration. And so these are diagnoses that have some distinct characteristics, but a lot of times there's some variations even among these, and they often have common impairments and that cause common disabilities. So what we're going to be doing is, let me just advance this, I think. There we go. We're going to be identifying the common impairments and the resultant disabilities that we find in these, and talk about some specific interventions that might help with the safety and independence for the person in their environment, because in all of these, falling is one of the big threats to an individual being able to stay functional and even stay living in their own home environment. Now, in our interventions, we're going to be trying to do what is restorative when that's feasible, restoring any kind of skills that might be able to be improved, would be compensating, using strategies that to help the person accomplish functional tasks that involve skills that cannot be improved. And this may very well include using adaptive equipment that's often needed. So when we're talking about progressive supranuclear palsy, among the major impairments are the postural instability, slowed reactions, bradykinesia, and the slowed muscle response. And all four of these first ones spell a greatly increased risk of falling. Often individuals are falling within their first year of being diagnosed with PSP. That's actually one of the red flags that lets a clinician know that what's going on may be PSP rather than idiopathic Parkinson's disease. So, but these increase the risk of falls with injuries. And as PSP advances, that risk of falling grows and grows. So Further on the list, there are other impairments from PSP. Vertical gaze palsy, which can increase a person's risk of falling, but also affect a person's ability to perform basic activities of daily living. So this vertical gaze palsy results in a person not being able to look down as well as they used to. Actually, it's greatly impaired, and that makes for individuals overlooking things, whether it be hazards while they're walking or food on their plate, any of these types of things. There are cognitive impairments that are associated with PSP, and these include decreased short-term or working memory, decreased ability to shifting one's attention from one group of data and to another, decreased ability to plan or execute a plan. So all of these things can make for an impairment in a person's activities of daily living, a greater risk of falling because not processing or reacting to hazards that are developing in their environment. And so other things that can be as part of the scene would be changes in swallowing, and this may be also related to the bulbar palsy. Bulbar palsy actually affects the person's ability to chew. It affects their speech and their voice quality, as well as just plain swallowing. And so as PSP progresses, the risk of a person choking on food or developing aspiration pneumonia increases. So we're going to be dealing with the functional impairments, and as I mentioned, those falls risk, that's the big threat to the individual's ability to remain independent or in their own home. And it also, with the decreasing mobility, it increases the burden on what I'll refer to as a care partner. That's a term we commonly use for the individual who is assisting this person in their living with this condition. So in later stages, the person may also be having higher degrees of pain or even be at risk for skin breakdown as their mobility decreases even more. This includes ability to just shift their weight in a chair or to get up and walk around to take the pressure off of the pressure areas. So impaired vision, this is a functional impairment for individuals, and it can certainly affect reading. It can affect ability to feed oneself. It becomes a great difficulty for even just plain quality of life, making a person more vulnerable to depression. Depression is a very common affliction for individuals with PSP. And I mentioned the risk of aspiration that does increase as the condition progresses. So with occupational therapy treatment in PSP, one of the things that we can do that is very important is actually increasing the patient's understanding and the care partner's understanding of what's actually going on, what is changing, and how this affects a person's ability to walk or ability to see things or ability to think, any of these type of things. And so we have to teach them to be proactive to decrease their risk of falls and help prevent injuries. This is going to mean they're going to have to change habits and routines. And so we'll be teaching them strategies and adaptations to help them perform tasks that they need to perform, tasks that involve mobility. And so we're just trying to decrease the risks of falls. This may be even such things as meal preparation in the kitchen, having them use the walker more consistently if they're needing to use a walker, teaching them ways to make that walker part of their whole task performance. So we'd be teaching them also compensation skills for accomplishing activities of daily living, compensating for decreased visual gaze, for the we call it bradykinesia, the slowed muscle speed and slowed muscle movement that can steal from momentum and making it very difficult for a person, for instance, to move in bed or to get up out of a chair or to perform any type of task such as this. Coordination is another area that individuals with PSP suffer with, and loss of fine motor coordination is what initially appears, and it progresses later to gross motor coordination as well. So we would also want to be teaching them exercises to help them maintain flexibility. Now, there's not lots of evidence specific to PSP or MSA or CBD for that matter about exercise being strongly helpful. There is a growing number of small sample studies that do support the exercise as an intervention that is worth introducing to the patient. And so, but there is also a broader degree of literature out there and research that supports neuroplasticity in general for all types of conditions. And then there's the wealth of evidence that supports just the value of exercise in general on promoting cognition, promoting stamina, helping preserve strength and flexibility. So there are a lot of reasons for helping the individual to develop an exercise program that is realistic, but that may be very helpful for them to prolong their ability to function as long as possible. Increased activity, as you may know, also helps a person to fight the chemical changes that can be feeding depression, or fight the feeling of being dependent and out of control that can be feeding depression as well. So we would be teaching the care partner also helping strategies. Now, this gets to be increasingly important as the disease progresses, because the care partner may be having to do a lot more physical assistance, including lifting an individual, helping them to stand, helping them move in the bed, and often the individual who is doing the helping may not be as large or strong as the individual who is requiring the help. So this is teaching them body mechanics and methods to cue an individual with PSP can be helping to keep them safe. Even such things as helping to inform them of the difficulty that the person with PSP has in even focusing attention, concentrating. So distractors at, for instance, mealtime, when the person with PSP is trying to feed themselves, if there are televisions or conversations or noise, this is making it much more difficult for that individual to perform coordinated body movements and to feed themselves. So also the adverse effect of feeling pressure to hurry up, which is the last thing an individual with PSP would be able to do with the super slowed muscle movement, and also the slowed cognition. And allowing the individual to rest when that's necessary. So also we want to be doing whatever we can to help the person with progressive supranuclear palsy promote activity, because part of the difficulty with PSP, apathy, is a very, very common part of the whole condition. And so you may have individuals who used to be very creative and used to have great initiative. Now they're sitting, not sitting happily, just sitting. And so very, very much vulnerable for greater depression, greater physical and cognitive decline. And so trying to teach the individual and the care partner how to deal with life when apathy is such a big part of it can be helpful. This may mean very well that they're going to have to add some structure to their week, where they are assisted to include daily activities, enjoyable activities, bouts of exercise that are realistic, as well as necessary activities, whether it be bathing or other things that they may have to include in that day. But just to make things happen, because if it's left to occur when the person feels like doing it, it's not going to happen. So other things that might be helpful would be linking the person with community resources, such as adult day programs or other things that can help a person to increase their activity level. Often you may have a care partner who is trying to get the person to do more, And the dynamics between couples is such that it's very, very difficult to accept recommendations or urging or encouragement from someone that you're very close to. And if a person is involved in some type of community activity or day program, they can often be led to participate quite happily in activities that a care partner wouldn't be able to bring them to. So let's look a little bit at some of the vision concerns in PSP. I mentioned that there is the loss of downward gaze, and so individuals may need to be taught to do some deliberate, conscious alternatives to this, compensations. So looking down, developing this as a habit or as a familiar response may spare a person some tripping or some difficulties with walking, certainly when they're trying to step up over curbs or thresholds. The individual may need to have protection from glare because unconsciously we avoid glary situations. And so an individual may be sitting even in their own home. They don't have to be outside in bright sunshine. They could be sitting at their breakfast table facing a window and having very uncomfortable glare that they're confronting. So they may need some light-colored sunglasses. They may need a hat with a brim, because sometimes even in the clinic you may find that an individual is squinting or struggling with the overhead lights, and it's uncomfortable for them. For function, they may need to have an object brought up into their line of vision, since it's difficult for them to look down. And some individuals may be able to learn conscious strategies. For some, it's not realistic to expect them to think of doing this over and over again. So in some cases, bringing things up into the line of vision can be helpful, whether that is their food or other things. As the disease progresses, the vertical tracking can also be, vertical and horizontal tracking can be impaired as well. So double vision is a common complaint. There's a lack of convergence, and some individuals may need to get prism glasses as prescribed by an ophthalmologist. It is known that a person might be better served by having a pair of glasses for near viewing and a separate pair of glasses for distant viewing, simply because what you need to do to use bifocals effectively is to lower your gaze, which is what we've said is not easy for them to do. It's not even possible for them to do. In some individuals, one encounters blepharospasms, which is where the eyelids are closed, that it is very, very difficult or impossible for the individual to open them when they need to. This may need some intervention by the physician in terms of Botox injections or other things. So interestingly, visual acuity may remain unaffected by PSP itself, although as an individual ages, visual acuity might be decreased just because of natural aging. Other concerns pertaining to vision, a person does have a reduced blink rate when they have PSP, and so they may be experiencing dry eyes. They may also have a greater sensitivity to light because of the decreased blinking. They often have an impairment of visual perception, an ability to judge distance, and this can make it where they become far more vulnerable to miss a chair that they're attempting to sit in. It's also a reason why individuals with PSP often cannot safely use power wheelchairs. There is that difficulty with judging distance, and also a difficulty with making the finger movements that are necessary to promptly correct any kind of controls in the wheelchair. So some individuals, some therapists have found that training of individuals with PSP in improving search patterns, teaching them to consciously be looking from left to right and lowering your gaze as you do, lowering your head position, that can be helpful for individuals to take in more of what they're needing to be taking in, because especially when they're walking. So when it comes to falls, as I had mentioned, a person would need to be encouraged to use a walker if this is what the physical therapist might be recommending. And in occupational therapy, we would be teaching them strategies of how to get in good and close and not abandon using the walker, as is the temptation for many people in their kitchen, to leave the walker and to take 2 or 3 steps while carrying a sandwich or so, and this is what often can be precipitating a fall. So teaching them how to effectively use a walker, teaching them other methods if they are not required to use a walker, or if there are specific instances where it's not even possible, such as in very small bathrooms and such. Teaching them the Tai Chi bow and arrow stance can be very helpful for them to with a wider base of support, to deter a fall. And then instructing them in compensatory methods of dressing, for instance, primarily sitting when they're putting on an over-the-head shirt, or even when they're trying to put on a jacket. And they may need training in some alternative ways of doing this, because it's not something they've had to face before. But even sitting when they're performing grooming tasks or such. Instructing them in home modifications that can decrease their risk of falling. Often this requires a home evaluation, because not every situation can be replicated in the clinic, and just seeing what a person is facing in trying to get around in their home and seeing what some of the hazards may be, it can be much more effective in making appropriate recommendations. So teaching body mechanics for a safe chair or car transfers, and this is something that doesn't necessarily come naturally, but individuals with PSP often have more of an extensor tone, which makes them very vulnerable to retropulsion, to falling backwards. And if you have to try and get out of a chair and you have an extensor tone, you're working very hard to get out of that chair. People need to be taught to very consciously to bring their upper body forward, to shift their body weight to make it easier to get up out of the chair. And at least as important is teaching them to bend forward when they're trying to sit down. Otherwise, they come crashing down out of control, which can be very dangerous. I am aware of several instances, even in our clinic, where toilet tanks have been broken off by individuals coming down very hard onto a toilet. Luckily, these individuals were not injured, but I think that the risk of that is quite obvious. So people need to be instructed in ways to be more safe in their transfers. And they need to be instructed in how to use the wheelchair for home function when that becomes necessary. And unfortunately, the rate of progression for PSP, MSA, and CBD is all rather rapid, ranging anywhere from 5 to 10 years for individuals reaching more advanced stages after the time of diagnosis, where they're quite debilitated and quite vulnerable to pneumonia and aspiration. But often an individual, if they can be encouraged to use a wheelchair, especially a lightweight manual wheelchair, they still can participate in independent and safe mobility within their home. They're also doing things as far as helping maintain their general strength if they're doing this with using their leg and arm strength. So when it comes to walker use, obviously we would need to consult with a physical therapist, but we would be teaching the individual how to use that walker in functional tasks. Often such simple things as a piece of cabinet liner, rubber mesh cabinet liner on the seat of the walker can be encouraging to an individual to use that walker as a tool to transport objects, whereas otherwise the person might be tempted to leave the walker and carry their cell phone, their plate with food, whatever that might be, short distances, which those short distances and confined spaces are even more difficult for an individual to maneuver in and puts them at a great risk of losing their balance. This is just an example of a rather specific walker called a U-step walker that is sometimes recommended for people who have PSP. It often does provide a broader base, as you can see with the U shape to it, that may afford the person more control and more balance support than a typical walker might. This would be certainly something that might be recommended by the physical therapist. When it comes to wheelchairs, this is something that occupational therapy very often is brought into the picture for, because it seems to be something that is sooner rather than later required for individuals with PSP. And the wheelchair needs to be very properly fitted to the person with PSP to maximize their ability to use it independently, but to use it safely. Often, it needs to be a hemi-height, unless you have rather tall people, so that the person can use both their feet and their arms as to propel this chair. The seat dimensions need to be specific to the person so that they don't have enough room to develop poor posture, but also so that they're not compressed in the chair. Removable leg rests so that an individual can get around within their own home, even in tight spaces. And extended brake levers are often necessary to bring the brake lever into greater range of visibility for the person with PSP. And often marking the ends of the brake levers with bright colored tape can be helpful, because they may not be seeing it with their central vision, but more with their peripheral vision. It also helps to act as a little reminder or a visual cue for the person to put the brakes on. A pelvic belt may be necessary if a person has a lot of extensor tone and resulting in the hips coming forward. Anti-tip bars are something that are often needed for individuals with PSP because of what I mentioned earlier, the difficulty of coming down gently into a chair and not crashing backwards. If that were to happen in a wheelchair, a person could easily tip the whole chair over. And it would be something to consider also having a pressure relief cushion, because as the PSP progresses, the individual is going to be in the chair more and more of their waking day. And also they're going to be needing greater sources of support, but they're going to become more vulnerable to tissue breakdown. One thing that also is worth mentioning is that when we're dealing with wheelchairs, it would be very helpful to be teaching the care partner the proper method of lifting such a chair into a trunk, just because that's often a huge barrier as far as the individual being able to participate in familial or social or community gatherings, is the difficulty for elderly to be lifting a 33-pound wheelchair into a trunk. So again, dealing with falls prevention. In this picture, you see a gentleman demonstrating the Tai Chi bow and arrow stance, which is simply one foot is positioned ahead of the other, and the other foot is turned outwards. Not necessarily 90 degrees, but at least a good 45 degrees. This creates a much wider base in 2 dimensions rather than just 1 dimension, and a person's ability to maintain their balance is greatly increased for this. Individuals also need to be taught not to overreach, and this may mean some environmental adaptations so that they're not tempted to overreach, and often lowering the height from which a person needs to obtain things, lowering clothes bars in a closet, or bringing items down in a kitchen to a more easily reached shelf, especially items that are frequently used. Other strategies would be getting the individual to sit to dress, removing throw rugs in their home so that they're not going to be as likely to trip over these, widening the walking paths, and this is something that can act as a narrow walking paths can act as a deterrent for an individual to use their walker consistently through their home environment, or for that matter to use their wheelchair if they need to do that. So sometimes this does not have to be a huge undertaking, but simply helping the individuals to identify how to do this, just to make the house more accessible. Smooth-soled shoes would be better than shoes that have more of a texture to them or a gummy sole, because individuals are not lifting their feet as high, and any contact that they make with the floor may result in the shoes grabbing, and that may help them cause them to fall. Again, still dealing with the issue of falls, the home evaluation may identify conditions, even such as one that's in this picture here, a cluttered stairway with only one stair handrail. 2 handrails would be better, and removing distractors from that would help decrease the risk of an individual falling. It may become necessary to have a barrier placed across the top of the stairway, because some of individuals with progressive supranuclear palsy do develop disinhibition, or a more impulsive type personality, to where they may intellectually understand cautions or strategies that we are teaching them. It doesn't mean that they're going to implement them. And often they may be getting up out of chairs unassisted and on their way to the floor even before they can get any help, or before they realize that they've made a mistake. So obviously, if this were to happen at the top of a stairway, an individual would be at great risk for injury. Grab bars at doors can be very helpful, because the big risk for individuals with PSP is the retropulsion, falling backwards. That seems to be the most frequent direction that individuals fall. Laterally is another way that individuals fall, but less frequently forward. For PSP, it's most often retropulsion. Adequate lighting would be helpful as well, just because individuals with the decreased visual skills and also a decreased contrast sensitivity, they need to be assisted to get the information they need to recognize changes in height, changes in angles or elevation, any of this type of thing. It can be helpful to mark corners of whether that would be countertops or coffee tables, or even such things as being mindful that open doors like cabinet doors or dishwasher doors, that these are major hazards for individuals to bump into and to fall over. So marking anything that might be sticking out into a person's pathway, especially if when they cannot look down, that this would be helpful as well to decrease their risk. This is a picture of a barrier gate that was installed in an individual's home, because even though the individual wasn't necessarily impulsive, there was a risk of him falling as he would enter through the back door of his home. That was his typical way of entering the home and going into the kitchen. And so to protect from a potential high injury risk fall, that this type of gate could be very helpful. It may be necessary for care partners to obtain motion detectors or different types of alarms if the individual that they're living with who has PSP has become impulsive, so that if the person gets out of bed and is going through the house at night, for instance, without assistance, even though they've been told that they should not be doing this, that the care partner can be alerted to this. So for impaired mobility, we would need to be teaching different types of exercises to promote trunk rotation, stretching exercises, anything that we can do to help fight this rigidity. And we're also going to be needing to teach the care partner body mechanics and methods of cueing the individual with progressive supranuclear palsy, because the person with PSP is going to be requiring reminders. It's not an automatic situation for them anymore. They're having to think about more and more of what they're doing, and they're going to require these little cues and reminders from the care partner. Cues need to be brief, they need to be familiar, and they need to be consistent to be effective. So, and we would also be training individuals in the use of the adaptive equipment, because unless a person gets to be familiar and comfortable in using it, it's not going to be effective for them. The adaptive equipment does need to be matched to the specific needs, the deficits and strengths of the individual as well. Here are a few thoughts of just ways to make transfers a little bit less hazardous and a little bit easier for individuals. A piece of satin, particularly satin that has flannel on the back, if it's applied to a fabric-covered seat, it can make the moving of the hips forward to the edge of the chair easier, and that can make a big difference in an individual being able to get up from the chair. The person needs to slide forward, and then they need to be cued to bend forward at the hips before they even attempt to stand up. And as I mentioned, they also need to be cued to bend forward when they're sitting down. Sometimes seat heights need to be raised, and this is particularly true of sofas, but even raising a seat height 2 inches can make a tremendous difference in a person's ability to get up from a chair. A 2-inch increase can be done by flotation cushions that people often have in their boats if they're fishing, bleacher type cushions, any type of flat cushion that is relatively dense or firm so it doesn't compress too much. If care partners need to be taught in the use of a transfer belt, because for PSP, as it advances, it's more likely the person will need to be assisted as they're ambulating, and a person who is trying to help them will be much more able to detect a loss of balance and be able to help the person come back into balance if they have something that they can grab onto. Toilet transfers are a situation that can be very hazardous for a number of reasons. The bathroom statistically is the most dangerous room in a person's home because it's a number of reasons. There is often low contrast between the various surfaces that a person has to identify and deal with. It's often with some wet surfaces. If a person does fall and hit anything, whatever they're going to hit will be hard. And so you can imagine if a person is approaching a toilet and often it's white, the floors are often white or beige, the walls are often white or beige, and there's a lot of effort that has to go into identifying where's the surface or the target that the individual wants to sit at. Toilet rails are often better than even grab bars in the walls as far as helping an individual to come down under control and right where they want to be. The toilet rails can be marked with a visual cue, as you see in this picture here with a piece of red electrical tape, in that an individual who walks over there and puts their hand on that red tape is likely to be very well positioned so that they can sit right on target on that toilet. Individuals may need to have a bedside commode or non-spill urinal because if they're needing to get up frequently during the night, this is a high-risk situation as well. Trying to get male patients to sit when they're going to urinate is another way for them to be able to cut their risk of falling. The non-spill urinal available at medical supply stores. Chair transfers, if an individual has the cognitive ability to safely use this can be very helpful for them. Car transfers can be facilitated by, again, the flannel-backed satin, making the surface more slippery if it's a fabric upholstered car. If it's leather, the person already has the advantage of the slipperiness. I have found that satin on a car seat is actually better than the often marketed transfer discs, the pivoting discs, which are not comfortable and are much harder for an individual to slide on. The marketed handy-bar can also be helpful for an individual to push off from as far as getting up. People will still need to be instructed in alternative ways of getting in and out of a car, because this is not what they are likely to have been doing for the past decades of their life. So positioning the hips against the car seat, sitting, and then pivoting to bring the legs into the car, and reversing the situation to get out of the car. One effective way of getting out of a car would be an individual, after they've pivoted and brought their legs out, to take hold of the door with the window open if the care partner is holding the door to stabilize it. This allows a person to use their own arm strength to pull themselves up to a standing position, which is much safer than an individual having themselves be pulled by the arms into a standing position. That will sooner or later result in shoulder pain and back pain for the person trying to help. So bed mobility, here we have the bradykinesia, the very slowed muscle movement, impairing an individual's ability to move around in the bed or even to get in and out of bed. And body mechanics can be very helpful in this, where helping an individual to bend their knees, raise their arm, and then roll, using the weight of the limbs to roll up from one side to the other, can be helpful. If the individual is so impaired that they cannot do this, getting into this position, a care partner is going to have a whole lot better leverage and less effort to assist the person to come onto their side off of their back. Again, the flannel-backed satin used as a draw sheet under the hips and shoulders can make moving in the bed much easier than if a person is, for instance, wearing cotton pajamas and trying to move on a cotton bed sheet. There's a friction that is just not helpful. The bed rail can provide some good leverage for individuals. Often individuals with PSP have very good arm strength. It's just not that they have difficulty putting that to use. So there are other types of equipment that may be better suited for individuals with PSP. The bed pole is one of them. In the advanced stages, a hospital bed may be absolutely necessary, because the care partner is just not going to be able to help the person to get up into a sitting position. Here you see the flannel-backed satin and a type of bed rail that can be very helpful for good leverage. The higher bed rails seem to be more effective as far as providing leverage. When it comes to individuals with retropulsion, as you see in PSP, pulling on a bed pole may be an effective way to compensate for that. The individual is drawn forward, they're able to use their arm strength, pull themselves up into a standing position, pivot, and lower themselves into a seated position safely. These are meant to be installed in individuals' homes. So when it comes to helping with ADL functions, OTs need to look at which functions are actually realistic for an individual that they could safely do, and that they're not going to be thoroughly fatigued in, or that they have adequate cognitive ability to perform. And so we would train them in strategies to help with this. So when it comes to eating, this is a very primary area that we can be of help. Eating being very important to a person's self-esteem, and also the fact that an individual feeding themselves, they're priming their swallow reflex, so far more than if the person is having food presented to their mouth. So whatever we can do to help them to be independent in eating, or at least independent in part of the meal, can be helpful. And among these things that we can do would be showing them how to bring the food up into the person's line of vision, stabilizing the dishes so that the person is not chasing the things around, increasing the contrast between the different items in front of the individual. For instance, a white plate with white chicken on it on a beige or white table is going to be far greater effort for an individual to locate that food than if there is some contrast. A plate guard is a common piece of adaptive equipment that OTs are familiar with that can help as well, and different types of utensils. Now, and I will show some pictures of these in just a minute. Strategies that can be helpful: removing distractions, eating in a quiet environment. A person may need supervision. Here we have the difficulty of some personality changes and impulsivity that may be making it harder for the individual to regulate their rate of intake. The food consistency may need to be altered, and this is where we would work in an interdisciplinary way with a speech therapist to find out what would be the recommended consistency. Addressing positioning needs, because often you'll find individuals with PSP have a hyperextension in their neck, or they may be having more of a lateral lean, and these need to be corrected as much as possible. Here you see one example of a way to raise the eating surface, bringing it closer into the line of vision for the individual. A covered traveler's mug can be helpful as far as protecting individuals from spilling as well. This is a commonly available offset spoon, which for individuals with PSP is often one of the most effective ways for them to bring food to their mouth with diminished spilling. Trying to use wrist flexibility to bring a food from a lateral position into a position that's oriented into the mouth is very difficult often. And the offset spoon and the offset fork can be very helpful. The offset fork is also helpful because it's easier for a person to spear food from directly above and then present it directly into their mouth. A universal knife may be helpful for individuals to cut their own food. This would be only more recommended for individuals in early stages of PSP, because in the latter stages where swallowing becomes more impaired and the difficulty in judging proper size of food portions gets to be more difficult, a person would need to have more supervision in this. So again, addressing the area of swallowing, we would consult with the speech therapist if there might be a need for a swallowing evaluation. We would be teaching the care partner methods to decrease swallowing risks: softer foods, smaller pieces, not being rushed, fewer distractions, making sure that the posture is optimized. A cutout cup can help an individual to keep their head in a neutral position when they're drinking. It may be inevitable that a person in latter stages needs to have a feeding tube because swallowing is just too compromised and the risk of aspiration is too great. Here are two examples of the cutout cups. Often the one with the broader cutout is more useful for individuals if they're wearing eyeglasses especially. When it comes to dressing, getting the individuals to sit either in a chair or on a bed, there's pros and cons to either arrangement. I do find that many individuals with PSP lack ability to sit unsupported on a bed, and so they may be pitching backwards, especially if the mattress is soft. So they may need to be seated on a chair. However, a chair does provide some restrictions to arm movements. But placing shirts and jackets in an accordion fold on a bed may enable an individual to put their own clothing on without the risk of losing their balance while they're standing. Velcro closure pants can compensate for a decreased fine motor coordination, and it also can help individuals when they have a urinary urgency to be able to deal with their garments in a timely way and not risk incontinence. Other things that are common pieces of adaptive equipment: step stools along. Now, a person may need to have a care partner there just to be there for assistance as needed to protect them from falling, or because they may fatigue before they're actually able to complete their dressing. In latter stages, due to difficulty with visual perceptual deficits, a person may be able to participate in dressing, but might have to have the clothing presented to them with the proper orientation. Examples of adaptive clothing either be with Velcro closures for the pants, for the shirts. When it comes to bathing and grooming and hygiene, this would be an example of a way to avoid having to step over a bathtub wall. An individual could sit and then be assisted with pivoting into the tub. It's not in the picture, but putting a black stripe of electrical tape over the tub wall can be helpful to identify where that tub wall is to someone with low contrast sensitivity. Adding colored tape to the grab bar at the far end of the tub bench would also be helpful for the individual as well. Handheld showers and grab bars are common pieces of adaptive equipment. A common hazard would be sliding glass doors, which for someone who has balance issues, these glass doors do not provide adequate support to prevent them from falling or even pulling the doors down with them. Hot showers, prolonged hot showers are not recommended for individuals because it can change the blood pressure, can increase dizziness for an individual as well. Using a terry cloth robe can help with some difficulties in getting thoroughly dried off. Strategies for an individual who still is able to participate in their activities of daily living and grooming in the bathroom. This should be done from a seated position, again, just to avoid the risk of falling. Toilet hygiene can be facilitated by different types of equipment, even such commonly used things as soft, wet wipes. One may need to be teaching an individual trunk exercises because with PSP, trunk rotation and axial rigidity is one of the common difficulties, and that would make it difficult for an individual to be reaching effectively. A bidet can be helpful for individuals to be thoroughly clean and not have to resort to getting back into the shower, especially if there are difficulties with incontinence. In latter stages, it does become more necessary to instruct care partners on the different types of incontinent products that are out there, and a catheter, whether it be condom catheter or indwelling, may become necessary as well. Telephone use can be facilitated with memory phones, simple type devices. So the simpler the better, but with large buttons so that an individual can access these effectively. An easel can be helpful either for mounting reading material or computer-typed electronic pads, just to bring it back into the individual's line of vision. These are marketed prism glasses that allow an individual to look directly below themselves to whether it be at food or whether it be at reading material. Leisure activities need to be adapted to keep an individual involved, to again forestall deconditioning, to forestall just a general lack of activity. And so bringing things up into a person's line of vision and reach can be helpful, and to decrease the risk of falling, having them do it from a seated position. Ceramics lends itself very nicely to individuals who have decreased fine motor coordination. When it comes to multiple systems atrophy, we are dealing with some similar impairments and some that are different. In MSA, one of the biggest problems is changes in the autonomic system. This can result in orthostatic hypotension, dizziness, causing a person to be at much greater risk for falls. Urinary incontinence gets to be a difficulty, constipation. So it is coupled with slowed reactions and just slowed muscle movements as well. It can be also affected by cognitive impairment, although typically the cognitive impairment in MSA is not as severe as what one may encounter in PSP. The cognitive impairment in MSA is more, there is some impairment to executive function and organization. You don't often see the impulsivity or disinhibition that you might encounter with PSP. Fatigue is a very common problem in MSA, and so helping individuals to manage the energy that they do have, and to deal with fatigue is very important. Teaching them strategies to do what they need to do with energy-saving methods. So occupational therapy treatment in MSA, again, informing them about how this disease is affecting their life with the different symptoms and how they play into an individual's attempts to perform tasks. Teaching them different strategies to proactively avoid injuries and falls. Teaching them exercises to protect their flexibility, their strength, their range of motion. A little note of caution with MSA. Strenuous exercise can result in vasodilation in skeletal muscle, and that can result in a person's blood pressure dropping, so that one needs to be mindful of that if a person is doing, in particularly, standing exercises. With MSA, one does have some vision impairments in terms of smaller saccades, impaired smooth movement pursuit, and there's a mild gaze palsy. So some exercises may promote some skills and ocular motor control, although there is not the research supporting this that what we need. There's a far greater need for research in this area, but it's right in the line with the neuroplasticity of promoting use of the muscles. And so whether it would be tracking different things on computer games, identifying things in the room, any type of things we can get to laser tag, any type of Wii games would be helpful for getting the person to promote eye movement. And that can have a definite effect on a person's ability to keep their balance as well. So teaching them compensations for skills that can't be restored, that would be something that OTs would be doing as well. Home evaluations, and trying to assist the individual to stay involved socially and in meaningful activity. Often this means addressing threats to their mobility and possibly transport wheelchairs or other types of devices might be useful. Now, individuals with MSA may be more in need of a power wheelchair, and fortunately are often more able to use a power wheelchair safely because they do not have typically the same difficulty with visual perception that you'd see in PSP. So, but other things that we would need to teach them to perform tasks without having prolonged static standing. So whether it be meal preparation, whether it be grooming, any of these types of things, to have them do things, changing their routines and patterns to avoid the static standing with the risk of drops in blood pressure. Carrying things in both hands, which poses a great vulnerability to falling if a person does stumble or feel dizzy. Clearing the paths in their home. Avoiding the Valsalva maneuver when meaning straining at stool. That can be affecting a person's blood pressure adversely as well. And for the individual with MSA, they're very vulnerable to this. Getting up from a bed, a person would not be well advised to get up quickly. The problem is that they often feel this need to get to the bathroom because of urinary urgency and fear of incontinence. But for them to go from a lying to sitting to standing position rapidly is very risky. So when it comes to activities of daily living, many of the things that we talked about that are helpful for PSP are also helpful for MSA because of decreased coordination and muscle control. The adaptive equipment and strategies can be helpful. Same thing with dressing. Individuals with MSA often have the cognitive abilities to continue using a computer, but they may need adaptations to desensitize the keyboard or have an ergonomically shaped keyboard or mouse or equipment such as this. Adaptations to the bed may be necessary as well. And this may include the need for a hospital bed to elevate the bed or having a foam wedge to help control changes in a person's blood pressure. because that blood pressure may drop, but it also may spike if the person is lying flat in the bed. A person with advanced MSA may need a wheelchair that has a reclining back, because anticolus, or forward neck flexion, is something that is a condition that a number of individuals do have to face. And with the decreased postural control and the fatigue, this gets to the need for additional support becomes evident. So incontinence management, this is done in conjunction with nursing and the physician. One strategy would be for individuals who are more active to continue toileting every 2 hours, whether they feel that they need to or not, to try and avoid these crises and bouts of urgency. Other strategies of limiting fluids after dinner. It's been recommended that some individuals raise their legs for about an hour before they go to bed, just to help shift fluids, and then they would presumably use the toilet before going to bed, and perhaps have one less trip that they'd need to do during the night. In teaching people in the different types of incontinence products that are available can be very helpful as well, and as well as having just such strategies as a bedside commode or non-spill urinal. Corticobasal degeneration, you have asymmetric symptoms, and it often results in just a decreased coordination, often in the upper limb. There can be changes in sensation, a lack of sensation, or pain, and often what's described as weird feelings, a change in the sensation in the affected side. You will often see bradykinesia, this can result in a greater risk for falling as well. Cognitive decline is a very common change for individuals with CG. The cognitive impairment, it can resemble frontal dementia, with memory problems, changes in personality, behavioral problems, all of which can put a person at greater risk for falls and injuries. Unfortunately, there is no effective treatment for the corticobasal degeneration. In OT, what we'd be trying to do is minimize pain and prevent contractures, and this may be by teaching extension exercises, and exercises where, if the person still has some bilateral use, trying to promote that bilateral use. And this can include different activities such as wiping a table, such as peeling a banana, husking corn, doing different types of things like this. Balloon volleyball, where a person would be encouraged to use both extremities. This can also be helpful for trying to promote still postural control and balance as well. So teaching all falls prevention. An individual with corticobasal degeneration is likely to be needing a wheelchair at some point as the condition progresses. And so teaching them and the care partner different types of methods of doing things within their own home, while trying to minimize the risk of falling. Cueing the patient becomes more necessary, and here too the cues are going to need to be simple, evident, consistent, because the individual with the corticobasal degeneration is going to be needing likely physical assistance in transferring from chair to chair or chair to wheelchair. They are likely to be requiring supervision at meal times, again because of the decreased cognition and decreased ability to make good judgments on portion size, bite size, and rate of ingestion. So we've come to the end of the presentation. Here are some sources for additional information about these three conditions, and I would open it up now to any questions that there might be.
All right, we'll go ahead and take some questions now. Thank you, Rick, for that wonderful presentation. At this time, go ahead and there should be a chat box at the bottom of your screen. If you have any questions, go ahead and type them in. and Rick and I will field them as we can. Again, if you have any questions, please go ahead and type them into the chat box, and we will answer them as we can. All right, Rick, it looks like there are no questions, so you must have done a really good job. I'd like to thank everyone for coming. I do want to remind everyone that this presentation will be available on our website for viewing at any time. So if you have coworkers or you'd like to rewatch the presentation, if you saw something in it that was helpful, you can always access it on our website under the Healthcare Professionals page under Education. All right. Thank you everyone for coming. Have a good day.